Welfare Initiative Development, Lafiya Nigeria. Please put your hands together to take the podium. Welcome, sir. One more thing before I leave. Please ensure to put your questions up on swap card. That's where we'll take our questions. Thank you. Over to you, sir.
All right. Good morning, everyone. It's afternoon, sorry. While they are trying to connect the screens and other stuff, the first part of my presentation is supposed to be about my personal journey and my involvement into Lafiya. And I don't know where she got it all from. And she have said it all. But I just want to add or ask this question. Is there anyone here, either in his community or in his family, that have not witnessed or experienced a woman dying from pregnancy-related causes? Is there anyone? Or you've never experienced, or your neighbor or any family or any relative within the community? You've never. Let me tell you these simple statistics. WHO have come up with a report and analysis that says in every 2 minutes, globally, every 2 minutes, a woman dies from pregnancy-related causes. And how many minutes do we have in a year? About 520-something thousand minutes in a year. And these 520-something thousand minutes, when you divide them by 2, it means every year we are losing about 260,000 women. A whole local government is being wiped out. Some of our local government are not even up to 250,000 population. And they are dying as a result of some preventable causes. For some of us that understand some of the culture, some of the beliefs in our local environment and our local communities, you have noticed that because of some belief that a man have the final authority or final decision, and because of some cultural perception that the ability of a woman is only seen when she is able to give birth to more and more and more children. I'm sure some cultures are like that. To the extent that if after giving birth to one baby, second baby, and third baby, if you are not giving birth again, the parents or the family of the husband can decide to say, your wife is not giving birth again. Can you get married to another woman so that she can come and give birth to so many babies for you? I'm sure some of you have seen that. So as a result of that, we look around as a group of people and realize that there are things we can do to address some of these misconceptions and some of these challenges. One of our co-founders happens to participate in the Charity Entrepreneurship Incubation Program, where some of these concepts were discussed and ideas were agreed. And we come together and said, okay, what is the best way we think we can support women to first improve on their health, make sure that they're giving birth to healthy babies, and also make sure we are reducing the quantum of death that are happening as a result of some of those pregnancy-related challenges. And we formed Lafiya Nigeria. Lafiya Nigeria was formed, and we registered as a charity organization, and we started implementing what we are doing in Jigawa State. From Jigawa, we then moved to Kebbi, and then from Kebbi, Sokoto, and then Kano, where we are currently working in 4 states. In this state where we are working, we realized, based on national data, national surveys, and other statistics, they contribute to the highest number of maternal mortality. For some of you that knows about the MAMI program that is currently being implemented by the Nigerian government, these states are already part of the state identified as states that are contributing highest in the maternal mortality in Nigeria. And that is why even the federal government have come up with an intervention to address some of those challenges. So we move into this stage. We engage with the stakeholders. We identify communities. We identify volunteers that are willing to work with us. And these volunteers are not just any kind of volunteer, but professionally trained health workers, nurses, midwives, and chiefs. Some of you knows about these cadres. And we upskill them and help them to acquire skills in terms of administration of a commodity, which is a self-injectable method of contraceptives. And we train them on it, and we push them into the community as part of the facility work they are doing already, because most of them are from facilities. And they continue counseling women, generally on family planning, with a focus on provisions of DMPSC. So this is what we do, and this is what we have been doing. Okay. I think I've explained our personal involvement. The people you are seeing are some of the co-founders that came from across the world. And some of you may be wondering, how does a black man like me get to co-found an organization with 4 white guys? With the kind of world where we are, with just a simple email, chat message, or anything, you can get to meet so many people, and you can get to network, talk to each other, and agree on certain idea, and start working to develop that idea. I had these questions during Skull Foundation meeting, during the EA Global London. People asked me, how did you come about meeting these guys and you formed these organizations? And we know it. When an idea is there and people believe in that idea, they can come together and do wonders. Okay, I spoke about the statistics, and I told you that out of this data, these women that dies after every 2 minutes amount to about 260,000 people. And I said it, a whole local government. And this is a global problem. And over 270 million women that want contraceptives could not access it. Believe me, a lot of people want contraceptive. You won't even know people who need contraceptive until when you go to a community, do a small sensitization, and you turn your back walking, and you see the long queue that will be following you, trying to ask more information, trying to ask how they can get it, trying to ask which method will be suitable for them. And then, in all this, what's happening? Okay, let me just continue with not necessarily with this slide. So in all this, you will notice that as Lafiya, when we come together, we identify the problem. What we first do, when we come to the community and we identify the local government where we are going to work, we work with the state government to identify these Lafiya sisters, as we call them, who I said they are professionally trained health workers. And these Lafiya sisters, when they are identified, we train them on the issues around family planning, we upskill them, and then we provide them with the Sayana Press. Sayana Press, as I said, is DMPSC. That is a commodity that is being produced by Pfizer, and is a self-injectable commodity. And this self-injectable commodity allows for women to take some doses home and self-inject herself when it is time for her next doses. So when she first interacts with our Lafiya sister, one of the things we do, we try to guide her to see if she will be able to self-inject, if she will have the confidence to self-inject. And when we see that she can do that, then we give her the doses that she will need to take home. And when she takes home, we have a system where we constantly remind her on what she needs to do in terms of when her next doses, when she's due for her next doses. Okay, so after we do that, then we mobilize them to go into the community. As they go into the community, they continue working creating demand for the contraceptive, counseling people, conducting outreaches. Through the outreaches they conduct, they do even house-to-house outreaches, and they make sure that through those outreaches, they identify people that are only agreeing to take on contraceptives and provide contraceptives to them. In most cases, not every woman that comes to us will be requiring DMPSC. And if she don't need DMPSC, we have some facilities where we refer her to, and from there she can access the kind of services she will be needing. So Lafiya Sisters counsel across all family planning methods, but what they do is they go with them the DMPSC, which is the available commodity that we procure. So when a woman needs that, they provide that to her. As I said, it's a 3-month commodity, injectable method. After the 3 months, you need to take it again for the next 3 months. So why are we even making sure that we have the take-home doses for self-injection? A woman will come to you with her needs. When she comes to you, she will tell you that, okay, what she needs is she wants to space her family for 1 year. She already tell you what she needs. If she already told you what she needs, will you ask her to be coming to the facility after every 3 months to take a dose? Or will you ask her to come monthly? Or what will you do to her? You give her all the options that will help her. And while giving her all those options, you tell her about the DMPSC, which is a self-injectable method which she can take home. By giving her those doses to take home, you are eliminating some things from her. You are eliminating the cost of transportation that she will be having running through the facilities. You are also what? Eliminating the wastage of time that she will be using to go and join the queue in the facility. And you are also allowing her to concentrate more on other things in her house. These are some of the things that we looked at here. And as we do that also, we set up a system. And what is the system we set up? We set up a system that will help us get the real-time data of what is happening across all these facilities and what is happening with the Lafiya Sisters. Already the national system have the HMIS system or the DHI system that collect data around all the health services that are being provided. But we come up with a system also that we added that we want to also, as an organization, we want to get data directly from what the Lafiya Sisters are doing and help us in planning what we are doing. And we come up with the Survey CTO. We all know Survey CTO. We customize it. And through the customization, we were able to set it up in such a way that we will be getting real-time data across what each of the Lafiya Sisters is providing in the community. And through that, we collect data that we can easily analyze, and government will also have their data through the HMIS tools and through the LMIS tools that are there in the facility. Each of the Lafiya Sisters, when providing services, make sure that her data goes back to the family planning register of those facilities. And not just the family planning register, they make sure also the data goes into the LMIS tools to show the level of consumption. What the national government do when they are supplying, they check to understand the consumption level, not just the family planning registers that are used. So consumption records are used for quantification of whatever supplies that are being provided or that are being brought to in country. So in all, what we hope to achieve is to help in helping women to have easy access to these contraceptives. And through this easy access to these contraceptives, we believe we can reduce maternal mortality, or we can contribute to the reduction of maternal mortality in Nigeria. Unfortunately, you cannot see the screen. I don't know why, but I will just keep talking. And whenever you can see the screen, I know it will be more engaging when you can see the screen, but unfortunately, this is where we find ourselves. So what are those things that drive our impact? First of all, we leverage on existing structures when we go to communities. We don't create a different structure. We make sure we engage with the government structure. The government structure that are coordinating health programs in every state are the State Ministry of Health and the State Primary Healthcare Development Agencies and other agencies. So if you want to succeed in every health program, you can't do away with these structures. So you have to engage with the ministry, get permission from them. Then they'll link you up if your program, depending on which agency will be responsible for your program, then link you up with the agency that will be responsible for your program. Something like State Primary Healthcare Development Agency. So in all the state, we work closely with the State Primary Healthcare Development Agency to make sure that we get buy-in, to make sure that we plan together, and to make sure that we coordinate the work we do together. And the State Primary Healthcare Development Agencies also link us up with all the other local government structures. Because in every state, there are other local government structures. What are these local government structures? For health program, when you go to a local government, you can find something like MCH coordinators, something like family planning coordinators, RH coordinators. So depending on your program, they'll also have to link you up with the officer responsible. And you have to continue working with that officer for sustainability and to ensure you are getting the needed support and to ensure that the local government structure are also helping you to coordinate what is happening in those local communities or in those local government where you are working. And again, we look at, okay, what is the investment that is there by government or by other partners? Why are we looking at those investments? We don't want to go to a place and duplicate effort. You may go to a place and by the time you are going there, maybe someone or an organization or government is already providing the kind of service that you want to bring. So you have to do that assessment and understand that, okay, you are not going there to duplicate effort, but you are going there to complement what's supposed to happen and improve on what's health needs that you want to improve on. Then we make sure the data tools that are there by government are what are in use. The survey city I mentioned is for our own internal use. But the data tools from government must also be used. And those are the HMIS tools that inform what goes into the DHIS and the LMIS tools that inform into what goes to Nigerian Health Logistic Management Information System. Okay. So, as part of this, in most of the states before we start our intervention, we conduct some level of research or evaluations. Those research we conduct are what we use to set up our baseline. Because you can't just go to somewhere and say you want to improve something without understanding the level where you are or what is happening in those environments. And we conducted a kind of research where we were able to analyze the difference in terms of contraceptive usage, and we focused on Sokoto. At the time we finished that analysis, when we were setting the baseline, in terms of the knowledge of contraceptive and use of contraceptive in our treatment group, only 2% of people have that knowledge. So after 8 months, when we go back and we do another round of assessment, there were about 56% of people that now have information about contraceptives and are using contraceptives, which shows what? A significant increase. Before then, there were no intervention in those communities. But that intervention of 8 months was able to help us and improve in terms of the utilization. What is that telling you? That is telling you that when people don't have the information on something, you hardly see them taking it or accepting it or using it. But when they have that information, you surely see them going up for it. That is one of the examples I cited, that as soon as you finish sensitization, you see so many people following you up, asking for information or asking you on how they can get access to some of those things. And so far, we were able to reach about distribute about 391,000 doses of contraceptives. And this year alone, we were able to reach about 169,000 new users of contraceptives. And these new users are new people that are coming newly, not a follow-up users, just entirely new. Just this year alone from January to June. And 43% of these users are first-timers. Of our total users are first-timers. While 38% of our people that we trained shows a high level of knowledge, skills. They have high level of knowledge that have improved over time as a result of what we are doing with them. So in terms of our cost effectiveness, we realize our program is 20 times more cost effective than most of other, let me say, give well supported funding. And I will show you some of how it works. Unfortunately, you can't see that. But what I want to show you is that, like Give Well top funders, like was mentioned yesterday, we have things like Malaria Consortium, Helen Keller, New Incentive, AMF, who whenever they are, the cost of averting debt for each of their programs, for instance, for Helen Keller, is $3,000 to $500,000. For New Incentive, $300,000 to $500,000 to avert one debt. And for Against Malaria, it's also $5,000 to $7,000. But for us, when we just do our analysis, which was led by Rethink Priorities, some of you know Rethink Priorities, they are one of the global researchers and evaluators. When we did that, the result shows that we are getting to 2,694 cost per averting maternal death. While per averting any death, we are going to $527. So when you look at $527 in averting death and 5,000 or 3,000, you'll be able to see how much cost effective our program is than the other programs. And some of the lessons we have learned in the course of this is that for any program that is around family planning, we notice that you will be able to help women to improve on her education if you want to further her education, because she will be held there, she won't have much kids to cater for, and she'll be able to space and go to continue her education. For some of you who are in universities, when you are giving birth every year, it means that you are missing every session. But when you are giving birth 1 year, then you do your maternity leave and you go back, it means that you have some space to continue with whatever education you are taking in. And it improves your social status. It makes you healthier to the extent that other people will be looking at you as a role model. Because you become healthier, and in some cases they will be talking to that, she's always looking healthier, she's this, she's that. And they don't know that, yes, you're actually taking care of yourself. That's what is making you to be as healthy as you are. And it increases the agency of women. It helps the women take control of their reproductive choices. Apart from taking control of their reproductive choices, it helps in empowering them because they are economically, because some of the costs they're supposed to be incurring are now being eliminated, so they can use those resources to cater for some other things that are not there before. So overall, we in Lafiya, what we're doing to improve universal access to contraceptives. Overall, that's what we're doing. Okay, this is the slide that shows how cost-effective we are based on the analysis by Rethink Priorities that was conducted. Then these are the lessons I've just spoke about. Then this is our vision for universal access to family planning. Thank you. That is all.
Can we give one more round of applause to our eminent speaker? Okay, we have, yeah. So please, we sincerely apologize for the technical glitches we experienced. You couldn't see the screen while he was presenting. Please accept our apologies. So we have just one question for this session, but there's an office hour with him. You can feel free to go right after this meeting till 2:30. But let's quickly take this question that came up while he was presenting. Modisser Mohammed said, she asked, how does Lafiya Nigeria help in addressing the issue of teenage pregnancy in northern Nigeria, where early marriage is culturally accepted?
Okay. Like I mentioned in some of the discussion I had, what we do is to create awareness first within the community. And as part of creating that awareness, we help people understand some of the benefits and the disadvantages of unintended pregnancies. And also help them to understand that, okay, if a woman is taking in when she's not ripe to take in, there could be some health challenges. So what we promote mostly is the health benefit of some of the things that we do that we relate to culture or we relate to religion that are not actually allowed by culture or religion. We know that there are some misconceptions culturally that push the responsibility of taking in or pregnancy to the woman. If a woman is not taking in, she is seen as incapable in northern Nigeria. Either as a result of child marriage, she was not due or anything, but all that is needed when a woman is married to someone, they expect her after 9 months or after 1 year at most, she should just take in and give birth. Nobody cares what her struggle is, what her tears are, what pain she is going through. All that matters is that we just want you to give us a baby. So for us, we felt, okay, what do we do? There are religious leaders, there are traditional leaders, and there are health workers that are all available within the community. Male engagement is one of the key approaches we do, where we talk to the male to help them understand some of these challenges. Religious leaders, where we talk to them to help them promote some of the religious perspective to some of these challenges. And then traditional leaders within the community mobilize communities, and we do carry out some outreaches to sensitize them on what needs to be done and what not need to be done. I keep mentioning it that there is nowhere in our religion, if I take Islam or Christianity, that says a woman should just be giving birth every year or anything. For you to give birth, what matters for a woman is her health first. Is she healthy enough to do that? Does she have the ability to do that? Or we just want to push her? The man will just be claiming that he's out there to look for what to eat, forgetting that no, he also needs to factor in the health of his family and make sure that for whatever reason, the family health is the most important thing that he should prioritize. I saw an experience where a man hearing that his wife she went to the hospital for screening, and from there they called him and they said, your wife is pregnant. He didn't go back home on that day. The next thing, he just took the next available vehicle and moved to Lagos. For 3 years, that man could not be traced. Why? That he has seen the struggle his wife went through. In 3 years, she taken 4 times, and none of the baby stays. So what are you saying about that? I've seen a case where another woman, while the baby is crawling, she's already pregnant with twins. And one of the baby is already prematurely dead in the womb. She started going to hospital to check what is wrong with her and everything. By the time they assessed and told her that, okay, this is her situation, they had to rush her for surgery and evacuate whatever is remaining in her. The other baby could not survive because she was just 4-month pregnancy as at that time. And that alone pushed her to say, look, I've seen death and I'm not ready to die. So what is the way out for me? Taking contraceptives. So yes, teenage pregnancy happens, and to tell you the truth, not just in the northern Nigeria, almost everywhere. It happened. So because some people see it as culture, some people see it as religion or anything, but what do we need to do? Let's continue talking to them to understand some of the challenges that can come with pregnancy so that they will be able to manage the pregnancy that comes with some of those early marriages. Thank you.
Thank you, sir. I think he has really done justice to his topic, but he'll be having an office hour, hall 2 boardroom. Please feel free to have more interactions with him. So thank you, sir.